Hi, this is Cindy Hudson, Director of Clinical Compliance with Arbor Rehabilitation, and thank you for joining me on this brief webinar for our home health therapist regarding some clinical considerations about discharge. So I have a quick photo here of a lady who is learning how to do a car transfer while maintaining a non-weight bearing status. And I've got this in here as a reminder that we really do want to make sure that we're looking at the full picture for what that person needs to do to function and remain safely in their home. When we think about the clinical landscape and considering discharge, we want to make sure that we consider the entire picture with all of the patients that we're seeing, what their discharge needs are, and what their risks might be for rehospitalization. So when we think about the discharge considerations, we want to make sure that we've considered if the person or the family are realistically going to be able to continue taking care of that individual in the home, given their current functional status. And we need to think about what other supports might be helpful for that situation, such as Meals on Wheels, community transport vans, Uber Eats maybe, if they're game for that, or grocery delivery service. Even though we may not be the one to activate those services, I guess I'll say, those are some things that we can at least trigger nursing or the agency or the social work to consider so that we have really looked at meeting all of their potential needs. If a person has a progressive illness, making sure we've considered if the support systems are in place for when that function further declines. Do we need to be a little bit more proactive about adaptive equipment training and recommendations for crab bars or walker or whatever the case might be? Making sure we're looking down the road for that person to keep them home and keep them healthy. Some other discharge considerations would be to consider really what environment is going to better meet that individual's needs. When we think about where they're at functionally, would they really better function in an assisted living or a group home, independent living campus, a SNF? So really think about what those options might be for that person in terms of keeping them safe and keeping that person healthy. It's helpful then to know the regulations related to the various discharge environments so we can make timely decisions and not lose out on some opportunities that would actually help our patients maximize their Medicare or insurance benefits. When we have concerns about the discharge plan, make sure you communicate those to the agency so they can get the social worker involved when necessary on a more efficient or prompt basis. And remembering that discharge planning is really everybody's responsibility. We all have a part to play in making sure that we've provided the best and most comprehensive service to the individuals we serve. Regulations for clinically indicated readmission to a SNF. So if that person was in a hospital, went to a SNF, now they've moved on to home care. When it's clinically appropriate, a person would need to return to a skilled nursing facility within 30 days from their date of discharge from that facility to continue to use their Part A Medicare benefits. So again, when we're trying to help maximize the clinical picture and for the family, the financial picture, if we have concerns about their discharge situation, we need to make those known sooner than later so that if it's appropriate for them to go back to a SNF, it happens within 30 days. For managed care programs, the rules are oftentimes the same as they are for Medicare, but they do vary sometimes per contract. And that, again, would be where you've got concerns, talk to the agency. They might need to look into that managed care contracts regulations so we can make things happen in a timely manner. So some indications for either a SNF admission or a readmission, because we know sometimes people come directly to home care from the hospital, but they might need to spend some time in a SNF, or they're discharged from a SNF and they might need to go back. So we need to make sure that we discuss all of those discharge concerns with the agency first, and we also would want to make sure that nursing and social worker are involved when appropriate. So if that person's going to need to go to a SNF, whether it's a readmission or for the first time with this episode of illness, making sure that we're aware that if they're having a decline in their gait status or their transfers, higher risk of falls, maybe it's time that they look into some stay at a SNF. If they've got a decline in ADL skills, including poor hygiene or episodes of incontinence, maybe they need a bit more supportive environment, like could be provided in a SNF. If there's persistent safety concerns for mobility that are not resolving, we know that when we start with people, usually there are these concerns, but if they're not getting better, despite our efforts, we would definitely want to consider what those options might be to keep that person safe and healthy. If they're having issues with getting their meals or medications, again, we would want to consider a SNF admission. And certainly any kind of increased confusion or some of the behavioral management challenges that are taxing to the caregivers, again, there may be time to consider a SNF admission, or they can monitor and regulate things a little bit more closely than what we can do in the home care environment. Some indications for a SNF admission or hospitalization. If that person is declining medically, then we need to definitely discuss those concerns with nursing. We need to look at areas like fluctuating vitals if they are really inconsistent, and that's a new thing for that person. That might be a sign of deteriorating medical status that would indicate a need for further medical workup. If they've got some persistent shortness of breath, some weight changes up and down, you look at them today and they look fairly normal. A couple of days from now, they look pretty puffy and more edematous, or they note the weight change. Again, we would definitely want to alert nursing. If they've got unresolved pain issues, increased weakness, or we suspect or we know that there's an onset of an infection, those kinds of things might indicate a little bit more medical monitoring would be appropriate, possibly in a hospital or a SNF. We want to think about our options for discharge placement. So remembering that assisted livings often will provide support for meals and medication monitoring as necessary. They all have a little bit of a different menu of services, but those are at least some of the basics. They can offer bathing assistance. For those that might be appropriate for an independent living campus, again, there can be some more distant support, but support available than being alone in a home. And there's certainly some increased socializing opportunities. Somebody kind of from a distance, keeping an eye on that individual to make sure they show up for a weekly bingo or whatever it might be. And again, this is where social work might be necessary to involve because they can look at the options given that person's financial resources. So we need to make every session count. We need to prepare for discharge on day one. So this, my little acronym here for M is for moving, get the person up and moving about their home on day one, considering all the challenging surfaces that might be appropriate. So if they need to navigate narrow spaces and tight turns and door thresholds and that type of thing, make sure that we look at that as soon as is clinically appropriate in that home. Don't delay on those things. For E, we want to ensure that we've considered an all-inclusive approach, what that person is going to need to do to stay safe in the home. Do they need to be able to navigate with groceries, have pets or children in the home that might pose a trip hazard, or need to do childcare or pet care? Do they need to be able to open and maneuver through locked doors? Car transfers, as I showed you earlier, picking up stuff from the floor. Can they get themselves up off the floor should they end up there? So we need to really make sure we're looking at a very broad view of all the needs that might be present for that individual. S is for self-care, making sure we've planned on day one for independence with bathing, ADL setup, getting the clothes out of that unusual closet or dresser, making sure they can get some meals or have food be provided in some way. And then for C, combining core tasks with function. So doing rote exercises is not necessarily fun or functional. So what can we do to combine what they need to do for strengthening with things that are functional for that individual, like putting away cans of soup and that type of thing on an upper surface? That might be a natural way of getting in some exercise. You probably know this by now, but a lot of payer sources don't authorize for a whole bunch of visits for home care. So we need to focus really pretty upfront on getting the essential areas resolved so that they're prepared to take the next step into their rehab process. So again, we might need to look at, are they appropriate for an outpatient clinic for further rehab? What do we need to do to make absolutely sure they're safe with where they're at, basically functioning with where they're at, getting them ready to move on to that next step? And be reminded that a lot of our local SNFs do have an outpatient clinic or will treat those residents as an outpatient. So if they know that therapy team at that skilled nursing facility, they like that therapy group, if it's appropriate, they can certainly go back there for outpatient care. Those are some things just that might help make that transition a little bit easier for the individual. With reassessments, those are typically the exception, not the norm, although I do realize that we frequently need more than 30 days. So you want to really carefully consider clinically what you need to do and where we need to go for skilled care for this individual. Our documentation needs to justify ongoing therapy then, noting the gains thus far to prove that they have potential to benefit from our services. But then we also need to carefully document the remaining skilled deficits. What is going to further take our knowledge and our training and teaching and education to get them to that next level of care. Again, as I said before, proactive discharge planning is real important. Making every session count is going to help hopefully minimize the need for those reassessments so we don't end up on day 29 realizing we haven't addressed steps yet or a car transfer. Be proactive with that discharge preparation. In order to avoid hospitalizations, this is something that's near and dear to both nursing homes and home care agencies' hearts because there is a penalty from CMS if they rate too highly with the hospitalization or rehospitalization rate. So we want to use the stop and watch forms. Those are on our website. Those are forms that can help educate the family or caregivers on the early warning signs of any kind of medical decline. We want to use the zone tools for patient and family disease management education. Those are also on our website. Knowing that we're doing a lot of teaching and training about disease, about monitoring the person's well-being, because we all are responsible for keeping our persons at home, keep them healthy, keep them safe, and that disease management education is just a part of it. So I've talked about our website, that is www.arborrehab.com. When you log on to that, you're going to see in the upper right-hand corner the employee portal login. When you go there, if you haven't already, you can register to have access to the employee portal. Once you're there in the employee portal, on the left-hand column, there's a whole section just dedicated for home health resources. Another section, because it's shared by our SNF counterparts as well, under HR and program forms. When you click on that tab on the left, that will open up a whole other screen with like TB test forms, that type of thing. Scroll down and you're going to see those zone tools, and that's what it looks like in the bottom right-hand corner of this slide. We want to make sure that we're well familiar with the vitals, and for First Choice, one of our primary agencies that we work with, they have expected norms for the vitals that are listed here on this screen. For blood pressure, upper and lower limits, pulse, respiration, temperature. Might be wise to jot this down and keep this information with you so that when you're going on a visit, you can remember what their norms are, because every agency is slightly different. We want to make sure that we communicate those vitals. So if we find that they are out of range, notify the agency, notify the physician. Obviously, if the person is significantly out of a normal range or symptomatic, call 911. The agency in some situations can allow a variation of what they consider the norm, because some people typically run high or typically run low. When they know that and they give you their approval that you don't need to call them every time it's within a slightly different range, that's fine too, but you do want to have that communication. And you also want to make sure that you're aware of those initial warning signs of a stroke or a heart attack. The initial signs of a stroke are, there's a mnemonic to help us remember it, which is the word FAST. F meaning facial drooping, one side face drooping or becoming numb. Arm weakness, one side becoming numb, as the A for this acronym. And then S for speech, as it's slurred. And if those things, any or all of those things are happening, even if it's transient and temporary, T stands for time to call 911, okay? So FAST is a quick mnemonic device to help remember the warning signs of a stroke. We need to know it, our caregivers may need to know it certainly as well. The common warning signs for heart attack, obviously the pain, chest pain or discomfort, that crushing feeling, lightheadedness or nausea, pain in the jaw, neck, or the back, pain across the shoulders or in one arm, and then certainly shortness of breath, sweating, those kinds of things can be obviously part of that warning sign of a heart attack as well. Definitely time to call 911 when you see those. When we think about comprehensive discharge planning, we do have a home care discharge checklist that will help us to remember to look at all the aspects of care that we might want to make sure we've addressed before we discharge that individual. This is also on our employee portal on the website. So you can see that there's some main bullet points here with exercise programs, making sure we've accommodated for any kind of cognitive impairments, making sure that they can navigate mobility in the community a little bit for doors and stairs, and so forth. So make sure you've kind of looked this over, either mentally check it off each time you're working with a person and preparing for discharge, or even just print it out and you can physically check it off to make sure you've addressed all of that person's needs prior to discharge. Some quick additional clinical reminders: topical medications, even if they're over the counter, like BioFreeze now is, the CBD lotions that are popular, they are not to be applied by us as therapists without a specific physician's order. So I know sometimes the person is going to say, hey, can you just please put this on my back? And although we do want to be helpful, we cannot do that for that individual at this point in time. And we need to simply explain, unfortunately, we don't have a physician's order to apply this medication, and we can't do that today. Remember to treat per the plan of care only, making sure if you're going to work on steps, you've got a goal for stair climbing, that type of thing, and be very specific with your documentation for all disciplines. If you're talking about, you trained them on safety techniques or adaptive equipment or whatever it is, name the adaptive equipment, be specific. Tell me what specific techniques you're working on or compensatory strategies. What safety cues did they need? Was it for hand placement, walker alignment, step clearance? What is it that you're cueing them on? So be very specific with your documentation. And remember to work towards that discharge plan on day 1. When we do that, that's going to help us to identify any barriers to that discharge plan early on. And then we might need to, we'd have the time to consider plan B or plan C if it needs to be a SNF or assisted living stay. So some final thoughts. We do want you to know at Arbor Rehab that we very much appreciate the considerate care that you provide to patients with each and every visit that you provide. And just as a quick reminder, you do have some resources through your program manager, Ashley Matthews and Summer McCormick, with their numbers listed there. Thank you for your attention.